So, good morning, everybody. I'm delighted to see so many people here. Indeed, this is a controversial session. Pre-hospital cooling, to some extent, this whole debate hinges on the outcome of the debate that's going to be had between the next two speakers. So we'll just have to bear that in mind as we go through this presentation. Having said that, what I want to try and do is directly address this question based on the evidence that we've got so far. And I think I've broken it down into sort of four main areas, really. Evidence that early cooling is better. That is, of course, making the assumption that cooling is good to start with. I want to focus a little bit on IV cold fluid, which I suspect is probably one of the commonest techniques for cooling at the moment. And then I'm going to talk a little bit about intra-arrest cooling, the evidence for that, and then try and summarize with where we are now. So the evidence for cooling in terms of being more beneficial the faster the onset and the faster the time to target temperature is quite hard to find in human data. So, surprise, surprise, we have to look at animal data to try and address this question. Shetal Sundra reassures me that that is indeed a picture of a Mongolian gerbil. I don't know if that's true. I'm sure there's some animal lovers in the room which will know. But this is one of, I suppose, several animal studies that show that if you look at, these are the times up here, these are animals that have been cooled for 24 hours, 32 degrees. And I want you to focus on the columns, bars with the crosses, and the lines here. And the first one, the one with the crosses, are where the delay to cooling is just 1 hour. And then the ones with the diagonal lines is where the delay to cooling is 4 hours, which I think is clinically relevant times. And what we're looking at here is essentially percentage of normal neurons in the C1 hippocampal area at 6 months. So it's unusual that they're looking at these animals way down the line. And I think you can see fairly clearly, and you can argue all about the fact this is animal data, it's rats, etc., etc. But if you look very closely, clearly there's a huge difference between onset of cooling at 1 hour and then 4 hours. So by the time you get a 4-hour delay, it's not nearly as protective as the immediate cooling. As another study, this time fetal sheep model, following a cerebral ischemic insult. And again, just focusing on the early cooling, 90 minutes here, versus delayed cooling at 5.5 hours, you can see quite a big difference if you just look at all these various neuronal groups. And this again is looking at neuronal loss. Quite a big difference between those two temperature ranges. So there's pretty good evidence for animals. And I focus very clearly on those studies that are clinically relevant, the difference between about 1 hour and say 4 or 5 hours. If you try and take that out to human data, it's actually really difficult to show benefit from earlier cooling, and I'll tell you probably why that is in a moment. So one of the few studies that's quoted, it's not a great study, and you can see just 49 patients intravascularly cooled, and they've used all sorts of fancy statistical analysis to try and show that actually time to target temperature, odds ratio of 0.7 for a good outcome for each hour delay. In other words, the longer the time you delay hitting target temperature, the worse the outcome. Not a great study in terms of quality. Similar things have been shown by the Hypothermia Network several years ago, except in this study when they looked at it, they could not show any significant difference in terms of time to target or duration of cooling in terms of association with outcome. So why are we struggling to show this? And it kind of doesn't make sense because we sort of step back a little bit. There's no doubt that hypothermia is neuroprotective. And anybody in the room who does cardiac anesthesia will know that if you apply cooling before an insult, it's clearly beneficial. So if we've then got studies that purport to show benefit of hypothermia after an insult, surely it's entirely rational that the earlier you start that cooling and get to a target temperature, the better the outcome. One of the major issues around a lot of the observational work, and of course the vast majority of data that we've got is just observational data, is that probably those patients with worst brain injury as a result of their cardiac arrest tend to lose their temperature control and tend to cool spontaneously quicker. And this here is just one example of the study that shows this quite well. And if we focus in here, this is esophageal temperature of less than 34 degrees here. And you can see the group that does worse, so that's the red bar, CPC 3 to 4, actually gets down to an esophageal temperature of less than 34 faster than the better outcome group. Do you see what I mean? So they spontaneously cool quicker, faster. And that clearly confounds all these observational studies. And that's the problem we've got. A smaller study, but I think that shows it really very well, comes from Mauro Otto's group in Lucerne in Switzerland. And they looked at these temperature differences on admission in all these cardiac arrest patients, and they've divided it into the survivors and the non-survivors. And if you look down at the seasons of the year, virtually every single one of these, the non-survivors have significantly lower temperatures at admission than the survivors, except in red in the summer, when it's completely the other way around. So when the weather is warm, if anything, these patients warm up. And that's quite an important thing just to bear in mind as we take forward what we should be doing for these patients. So if we think that earlier cooling is better, and you can see already from the small amount of data I've shown, there's no really hard evidence for that, but if we do believe that, then clearly it would seem to make sense to start cooling pre-hospital. And as I've already said, the commonest way of doing that is with cold IV fluid, and that's just an example of the kit that Steve Bernard uses from his Melbourne group for pre-hospital cooling. And we've got a whole load of data out there. The first, 4 or 5 of these studies are observational studies, just looking at the effect of cooling in terms of temperature reduction. And generally speaking, if you give around about 2 litres of ice-cold fluid to people, they will cool down by about 1.5 degrees compared with those not pre-hospitally cooled. And there appeared to be, in all these initial studies, no major problem. And then the bottom 3 here are all randomized controlled trials. And again, they appear to show no harm from giving this cold IV fluid and temperature reductions, as you can see on the table there. So it all seemed fine and good. And of course, it's cheap, et cetera, et cetera. And then when we look at some of these randomized controlled trials, and this is the sort of more detail of that Bernard one that was in that last study there. If you look very closely here, temperature at hospital between paramedic cooled, so IV fluid started pre-hospital versus delayed until hospital. Temperature at the hospital in these 2 groups, again, you've shown clearly a benefit in terms of reducing that temperature, about 1 degree plus between those 2 groups. But look how long it lasts for. By 1 hour in the emergency department, this next row here, there's absolutely no difference between the 2 temperatures. So it's a really subtle difference. It's lasting for maybe an hour or so in this particular study. And they showed similar things actually in their non-shockable rhythm study. Just for the record, absolutely no difference in terms of outcome for these patients. So this is his non-shockable group, showing much the same thing. Temperature at hospital, again, significantly lower in the paramedic cool group. No difference in outcome, but it's a fairly small study. So it appears we can drop temperature with this fluid. In those studies, there was no harm from doing that. And I guess the controversy really takes off now with this much more recent and much larger study from Kim in Seattle. And they've looked at 1,400 or so patients, randomized to either receive pre-hospital IV fluid or delay until in hospital. And these, of course, are patients that have achieved return of spontaneous circulation. So it's after ROSC, which is important. I'll come to that in a moment. They divide them into shockable and non-shockable rhythms. And if you look very closely at these numbers, there's absolutely no difference in either survival to hospital discharge or survival neurologically intact. No difference whatsoever in outcome. So disappointing from that respect. But what was far more worrying was some of the secondary outcomes. And here we've got rearrest during transport significantly higher in the intervention group, those that received IV cold fluids pre-hospital. And if you look at the first PaO2, significantly worse in the intervention group. And then if you look at the incidence of pulmonary edema based on the first chest X-ray, significantly worse or more pulmonary edema in that intervention group. So in other words, we've got evidence here for the first time suggesting harm from using uncontrolled pre-hospital IV cold fluid. What about cooling intra-arrest? We've already said we know from cardiac surgery, if you can cool people before the insult, it's clearly beneficial. So why don't we just try and cool people during the arrest? Again, we've got our little furry friends to suggest there may be benefit in doing this. It's just a small animal study from Benabella's group, showing with intra-arrest cooling of these animals, that more of them survive. It's a tiny study, but it's just some evidence that it may be beneficial. And of course, others have taken this to the clinical setting. Steve Bernard's group is still ongoing with this RINSE trial, where they're actually giving up to 2 litres of ice-cold saline pre-ROSC, so during CPR. I think this is more challenging because there is quite good evidence there may be harm from giving significant fluid loads during cardiac arrest. And this is a study you can see that goes back 30 years. Again, it's an animal study. Dogs, I've given the weight of the dogs because this is important. They were given a litre of fluid intra-arrest. And broadly speaking, you can see if you look at aortic pressure, it goes up with volume resuscitation, but right atrial pressure also goes up even more proportionately. And so if you look at your atrial to aortic pressure, or aortic to atrial pressure difference here, you can see actually that reduces. In other words, flow reduces. And it's better shown in these slides here, where if you look at cerebral blood flow, this is before and after volume loading, during cardiac arrest, a significant reduction in cerebral blood flow. So large volumes of fluid, potentially harmful. Same thing for myocardial blood flow. Again, much, much lower after volume loading. So we have to be very cautious, I think, about giving fluid intra-arrest, and it'll be interesting to see Steve Bernard's results. So there are other ways of cooling, particularly that can be used intra-arrest as well. And this, of course, many of you will have seen. It's the intranasal cooling system. It essentially uses perfluorocarbon here, drives oxygen through it, and it's using the latent heat of vaporization as this stuff is driven through these long nasal cannulae. We've had one study, the PRINCE study, showing certainly that you have a cooling effect from the right. This is the Rhinochill system here in blue triangles. And you can see when started during cardiac arrest here, you've got a significant cooling effect. So that in fact, if you look at the time to target temperature, 34 degrees at this point, it's significant. It's about 190 minutes, I think, earlier than the group that were just delayed cooling until they arrived in hospital. So it certainly cools down faster than not doing anything at all. There was no difference overall in terms of survival, but if you think about it, this is a really small study. So it's only, 150 or so patients. And then subgroups, of course, if you look at those that received professional CPR inside of 10 minutes, then there seems to be here benefit for those that receive that Rhinochill system. But of course, that's a subgroup. And of course, this group are now going on with the current PRINCESS study, which is very much looking specifically at these cardiac arrest patients where the EMS to CPR time is less than 15 minutes. They're excluding those of longer than 15 minutes, so they can really focus on perhaps the better outcome group. And that study is ongoing at the moment, so we'll wait and see the results of that. And then this is, I think, very interesting, another potential technique for cooling both during cardiac arrest and after return of spontaneous circulation. And this is from a Japanese group. This is the study they've already published in Anesthesiology. It was a primate model, and you can see here what they're using is it's almost like a modified supraglottic airway device. So it's a pharyngeal cooling cuff through which they can infuse 500 mils a minute of ice-cold saline. And you can see here, looking at, this is, I don't know if you can read it from the back of the room, but these are brain temperatures, subcortical and epidural temperatures here. Clear separation in the two groups of primates in terms of a brain cooling effect by doing this, because of course you're directly underneath the brain as you're doing that. I can say that this group has the paper in for their clinical study of about 108 patients has been accepted in resuscitation. I can't show you the data because it's not in the public domain yet, but it's definitely accepted. And the one thing that I will give you a slight clue about is if before you get too excited, the machine that is used to cool and circulate this fluid is huge. So there is no way, as far as I can see from the photograph, that you are going to shove that in the back of an ambulance. So that at the moment is something which I think could be used in hospital. But I think it's quite exciting because it doesn't have the same potential problems as IV cold fluid, and it does seem to produce quite a rapid cooling effect, targeted particularly at the brain. So if there's going to be benefit from this therapy, I think that's quite an exciting development. So that's a paper that's worth looking out for. Probably in the next couple of weeks it'll come out online. So to summarize, to try and address the question, I'm going to say from the outset that it is highly dependent on the next two presentations, clearly, and that's why I think the chairs have agreed to take questions at the end of the whole session. I think, though, that what we conclude on what I've seen so far is that we should not use uncontrolled pre-hospital infusion of high-volume fluid, as was done in that Seattle paper. And I think that this will be reflected, well, I know this is going to be reflected in guidelines that will be published very soon. So that is a sort of recommend against. I think we would all accept that hypothermia should be avoided. I haven't shown you any data around that at all, but I'm just making that as a statement of fact that I think most people in the room would agree with. I think we have to wait the outcome of Steve Menard's studies, the RINSE trial, and of course the Princess trial, a lot of ongoing studies at the moment, because I think it does make sense that intra-arrest cooling should be more effective as long as it's not high volume fluid. And then, of course, as I've already said, really the question of whether we should be actively cooling pre-hospital is largely dependent on the target temperature that we elect to select subsequently. And so with that, I will leave it to my two heavyweight colleagues to slug it out for target temperature. Thank you very much for your attention.